Yeah, thanks for having me. Hey everybody, I'm Amelia. Meryl asked if I would give a presentation on supporting trained clients through medical transition, especially because lots of people have questions about like specifically how to write like a WPATH compliant letter and help trans clients access medical care and like navigate the gatekeeping that goes on. So I'm gonna try and help with that as well as some other stuff today. Um, just an overview. Um, with part one, we're going to do some tips on creating a trans inclusive practice. Part two is common approaches to medical transition. Part three, therapeutic interventions. Part four, their resources. And part five, how to sensitively write a WPATH letter. So first up, a note on the language here. I'm just going to minimize this. The presentation, I'm going to try to use affirming language whenever possible, but I use medical language when I need to. A lot of the medical language about trans people is outdated. It's sometimes harmful and often inaccurate. In particular, the ICD-10 is just hot trash. So please take care while listening, and please know I wish I wasn't using some of the words I'm about to use. Oh, and another quick note on the ages covered. I'm going to focus pretty much on adults during this presentation. There are some additional considerations and possible interventions like puberty blockers and so on when you work with children and adolescents. Maybe we could like dragoon Margie Thompson into giving a presentation on that. Mostly everything I'm going to talk about to support adults, though, in this presentation is still best practice when you're working with children as well. But just know there might be more to learn and do with kids and teens. Okay, part one, tips for creating a trans welcoming practice. So first off, some simple things you can do before you begin. You can display welcoming signage like progress flags, or in my office, I have a little sign from Kindred Post about like trans people are welcome here. You can introduce yourself with your pronouns, like, hey, I'm Amelia, she, her. And you can also check like, are your bathrooms and signage inclusive, and do you need to change anything? Like if a non-binary client comes to your office, is there a clear place for them to use the restroom, or is everything gendered? So just knowing those things and having the space ready to be welcoming for trans clients is a good place to start. A few more tips: you can ask for gender identity and pronouns on intake paperwork, and I ask again in person. I especially do that with teens. Really, even if they are sort of presenting cisgender, I always check in like, oh, hey, Scott, is that the name you like to go by? Just a nice way to double check. You can explain that you might need a dead name and birth gender if they're required by their insurance. And that's just a nice way of clarifying that you don't need them for your own like edification or your own curiosity, but it's just a legal requirement to bill insurance. Okay, next you can ask yourself, what do I know about the trans and queer community and how do I know it? So in my experience, there's been I've run into a lot of people who think like, well, I'm accepting of LGBT people and I view gay relationships the same as straight relationships and trans people the same as cis people, so I must be good, right? But I really don't think that that's sufficient to being a gender affirming therapist. You need to be educated on trans and queer experiences and issues like really in order to be culturally competent. So seeking out, I'm going to give you lots of resources today, but seeking out those resources and doing that learning, I think, is a required part of being gender affirming. And then another good thing to do before you even, as you're beginning to dive into things, and especially if you're talking about medical transition, is checking what a client calls the parts of their body before asking about them. If you're asking about somebody's penis, that might not be what they call it. And so checking with somebody first is a good idea. All right, part two, common approaches to medical transition. So I'm going to provide an overview of the most common approaches to medical transition here. It's not exhaustive by any means. Um, it can feel like quite an information download if this is new to you, and it might feel like we're getting a little in the weeds here, but I promise it really is an overview of the information, and it is just the basics. Getting into the weeds would probably be a multiple hours long presentation that we do not have time for. So real quick, categories of transition, to see how we separate these things out and why we're specifying medical transition, because there's also social, like our dress and name and pronouns, and legal transition. And the medical transition, we're normally talking about hormone replacement therapy and surgical interventions. So like almost all out trans people will engage with at least one of these. Most will do multiple, and some, like myself, will do all of them. The lines between each category can be blurry, and they're just general categorizations. There's no hard lines here. Note, I put voice with an asterisk because it can be a social change, like through vocal training, which is what I've done, but there's medical interventions for feminizing your voice or brightening your voice, as well as hormone replacement therapy. If you're taking testosterone, so masculinizing, it'll deepen your voice. So even that, it's like, whether it's social or medical, depends. So yeah. All right, so we'll start with masculinizing hormone replacement therapy, or HRT, which I think is what I'll call it from now on. The main one is taking testosterone. There's a bunch of different ways to take testosterone. There's subcutaneous or intramuscular injections, there's gel, there's patches, there's pellets. But that tends to be the main approach, is just taking testosterone, or T, as most, at least adolescents call it. Or people sometimes use like funny names like, oh God, what did that client call it? They called it antihistamines, which I thought was funny. All right, what are the effects? Well, you'll get some that most cis men get with taking testosterone, like male pattern baldness, a deepened voice, increased facial and body hair growth. And you'll also experience bottom growth, so primarily like clitoral growth on testosterone. And you can see, oh, I should have mentioned, let me go back a slide. If you do want to learn more about it, this book is excellent, The Transmasculine Guide to Physical Transition by Sage Butch. And that's also where the diagram on this page comes from. And hopefully sometime next year, the Transfeminine Guide by me will be out. So we're hoping on that I find more time to write and that happens. Okay, so the clitoral growth, and then reversible. So these are things that if you stop taking it, by reversible, it means if you stop taking it, will they go away? The libido and energy will increase, or will decrease if you stop. There's skin oiliness and acne, and your skin texture changes, increased muscle mass. It also will redistribute how you put on fat. There's a sensation of menses, which returns if you stop taking testosterone, vaginal atrophy, and there's changes in orgasm and the related sensations as well, depending on the hormones. Feminizing HRT. So there's typically two to start. Most people start with estrogen and anti-androgens. And then a lot of folks are also starting to add progesterone to part of the HRT regimen. So for estrogen, there's sublingual pills, which are, I think, by far the most common, and then patches, and then injection. Injection, I think, used to be more common, and then there's a period where it's hard to get. It was a whole thing. There's anti-androgen pills, which come in pill or capsule. In the picture, there's spironolactone, which is the most common, but there are others. And then, yeah, you can take progesterone in a capsule as well. And the effects here are typically the irreversible one is breast growth. Possibly irreversible, but there's some evidence that it is there's testicular shrinking, decreased sperm production. And then the ones that are reversible are the thinning and slowing body hair and facial hair. cessation of male pattern baldness, and there's a lot of anecdotal evidence that there's some reversal of male pattern baldness, but that's not supported by like peer-reviewed research yet. So who knows? Lots of people say that it happened to them though. Skin softening and fat redistribution, lowering libido and energy, and fewer erections, and again, changes in orgasm and sexual function. And then this always makes me laugh. Trans people hormones have made me finally feel good about and at home in my body for the first time in my life. And cis people say, but aren't you worried that might be irreversible? And so that's I think what you'll find is like part of the informed consent that doctors often give is like, these are the irreversible changes. And it can, and in my own experience, was presented in a sort of way of like, here's the things you should be worried about. But it's a weird thing of like, those are the things I want. Like, oh, breast growth is irreversible. Good. That's what I'm looking for. So yeah. All right, there's masculinizing surgical options. So there's a meta, which is releasing most people call it a TDIC, which is the enlarged clitoris from testosterone, and removing the labia minora. That's typically covered insurance, but it can be anywhere from $4,000 to $60,000 for out-of-pocket. Phalloplasty, which is creating an average-ish cis male-sized penis from a donor site on the body, which is often the forearm, but can also be the thigh. Again, that's often covered by insurance, but if you need to pay out of pocket, it's $25,000 to $35,000. Scrotoplasty, which utilizes labia majora to create a scrotum and use implants like silicone, I think often implants to create testicles. Again, should be covered, but if you need to pay out of pocket, it's about $5,000, but that can differ. And then top surgery, which is breast reduction. There's a whole bunch of different options for how you do it, and a lot of it can depend on like the shape and size and so on of the breast, which it should be covered, but again can be $7,000 to $15,000 if you pay out of pocket. Feminizing surgical options. So there's facial feminization surgery, which is typically out of pocket. There are more states now, like the whole West Coast of Washington, Oregon, California. It should be required to be covered by private insurances. So like Minnesota, Massachusetts, and I think some others as well. It is not a required cover thing in Alaska. I actually have a letter from Blue Cross that says, if I want facial surgery, that's cosmetic and I need to pay for it. But if I want breast implants, that's not cosmetic and they will pay for that. I don't know how you reconcile that, but they try to. So facial feminization, it can be any combination of all these procedures listed, like hairline lowering and brow and orbital bone reduction and eyebrow changes, rhinoplasty, upper lip shortening, or like whatever the space between your upper lip and nose is, lip injections, cheek injections, chin and jaw contouring, and a tracheal shave, which is the Adam's apple. Most people in my experience and most trans femme people I know don't do all these things, but rather some combination of them that they feel will relieve dysphoria and aid in their transition and passing and so on. But yeah, typically quite expensive. There's vocal feminization surgery, which is again out of pocket. It can be $5,000 to $9,000 or $10,000. There's a lot of risks with that, and it does tend to be a pretty high risk thing where it can have lasting negative impacts on your voice and vocal cords, as far as I understand it, but it is an option that some people take. There's breast augmentation, which is often covered by most states, including Alaska, but out of pocket for $12,000. And then lastly, there's, as people like to refer to it as the surgery, there's vaginal or vulvoplasty and an aneurysectomy. Again, typically covered. It can be $25,000 up to some astronomical numbers out of pocket, depending on where you get it done and by whom. But yeah, those are the main surgical options. And a note on non-binary folks, NBs, and other gender non-conforming people. I want to note that I use the terms masculizing and feminizing, or not like any essentialist language, because someone does not need to express a binary gender identity to access affirming medical care. Gender dysphoria is identifying as a gender other than your birth one, and that gives you access, or should give you access to the same surgical interventions that exist for binary trans folks. So just not everybody knows that, but yeah, I'd like to note it. All right, part 3, therapeutic help. So, so the approaches here are what I think are helpful in specifically helping a client with their medical transition. Like my own approach to therapy is generally based on like EMDR and IFS, but I'm going to present approaches that, excuse me, don't require specialized training and directly support transition goals. So I hope that these are things that any therapist could use to help a client. So first is, I know lots of therapists utilize person-centered therapy in some capacity, but just some considerations when working with trans folks, especially talking about transition. I encourage people to be not extra careful about their non-judgmental approach, because I think it's especially important when working with trans clients. We spend most of our lives learning, in most of our cases, to hide ourselves due to other people's judgments. So if a clinician expresses judgment, sometimes even positive, about our transition, that can cause a rupture that goes quite deep. So that non-judgmental attitude, I think, is extremely important. On the issue of empathetic understanding and reflection, everyone has, of course, their own gender identity, and almost all people, including cis people, struggle with aspects of it, including other people's expectations. However, I think gender dysphoria in trans people, like in my experience, is something different. It's a bit like thinking that because you can see colors, that if somebody else sees a color you can't, you understand their experience. Well, conceptually, yes, but experientially, no, you don't. The poet Adrienne Rich, she has this beautiful quote about if someone describes the world and you're not in it, it's like looking into a mirror and not seeing yourself. But I sometimes wonder, like, what is it like to look in the mirror and see someone else entirely? It's not the same thing. So my recommendation is to be careful with your reflections about dysphoria and to stick to simpler reflections until you feel confident you understand deeply your client's personal experience and how they've experienced their dysphoria, and to remember that cis dysphoria and trans dysphoria aren't the same thing. We can use problem solving and solution focused therapeutic approaches. In particular, there's a model by I don't know how to pronounce, I hope I pronounced their names right, Deserel and Nezu. And so you can use these approaches to help clients explore assessing what interventions would be beneficial to them and what would help, how to pay for those interventions, what may or may not be different afterwards, and developing realistic expectations of the impacts of these things. Like, I mean, I've certainly worked with clients who are like, once I have facial feminization surgery, I will pass all the time. Maybe, but maybe not. And similarly, we can use them to help clients differentiate dysphoria from dysmorphia. So dysphoria is that distress caused by the incongruence between our physical features and our experienced gender identity, whereas dysmorphia is an incongruence between one's experience of their body and the perception of their body by other people. So dysphoria might sound like, my inner experience tells me I should have a penis, but I don't. And that incongruence causes anywhere from mild to extreme distress. Whereas dysmorphia might sound like, I think I'm fat, but my doctor and family and friends all perceive me as within normal limits. The differences between these can get blurry when we're talking about medical transition with trans folks. For example, in my own experience, like I get dysphoria from having wider shoulders and being really tall. But many cis women, including even like friends of mine, have similar heights or body shapes. And so determining like, am I experiencing dysphoria or dysmorphia? It's not straightforward, and that's fine. It's okay. We can tolerate some uncertainty. And determining if I should get, for example, like if I should get rhinoplasty because I think my nose is ugly, or would it genuinely feminize it in a way to relieve dysphoria? Well, it can be a valuable endeavor to try and figure that out. In my notes, just for clinicians, I typically write this up as depending on sort of what flavor of it we're doing. It could be like solution focused work or problem solving work or just psychoeducation. And last intervention to talk about is feminist theory intervention. So at least what I think of as the three core parts of this: to acknowledge, to process, to skill build. And so we can acknowledge things like that these interventions might be inaccessible due to cost. And we can help with the grief that follows from that and the anger and rage. We can acknowledge that trans people's healthcare is politicized and unequal. We can process the pain of what I think of as the ambivalence to action due to safety concerns. So somebody might be ambivalent about some part of their body, like they might be ambivalent about doing facial feminization surgery, but they're motivated to action because they're worried about not passing and about facing violence because of that. And so you can help process the complexity of this, that in our world, if you want to live as a trans person completely safely, passing can be an important aspect of that. And so that might mean doing interventions that if there is no threat of violence, you would not do them. And that gets complicated. We can process concerns about age. I have had trans kids in middle school tell me they are too old to transition, just like a wild thing to hear from somebody who transitioned like when I was 30. So we can help process that though, because there will always be a belief that I am too old for lots of folks. We can process pain of being forced to undergo a wrong puberty. And that can be tough. There's a really lovely book by Alex Infante called Gender Trauma, which covers the ways in which going through a puberty that you didn't want to, or isn't what you expected to happen or what you want to happen, and it's just something completely outside your control, is traumatizing. You know, I almost want to like conduct a survey on how many trans folks relate to the metamorphosis, because I think there's something to that. And then last, skill building. In particular, we can build assertiveness skill building. So like also as well knowledge on like the relevant laws and regulations to empower our clients, because insurance companies will be typically quite difficult to deal with on these things. And so helping somebody have the skills to assert themselves, to know what they are entitled to know how to engage and access these systems, really empowers the client. And so that can be a really good use of our time. All right. So part 4, education and resources. Some of this I'll go through fairly quickly in just hopes that like you can come back to it. Meryl's recording this, you can come back and see what they all were if I go too fast. Journals. So the one that I probably go to the most is the Journal of LGBT Issues and Counseling from SAGE, which is a division of the ACA, or part of the ACA anyway. There's also pretty good the Psychology of Sexual Orientation and Gender Diversity from the APA. There's the Journal of LGBT Youth, and then including it because it is the standard, but I don't particularly like it, the International Journal of Transgender Health, which up until 2020 had the wild title of the International Journal of Transgenderism, which is just something else. There's trainings that you can do. Again, SAGE has lots of wonderful trainings. I've done many of them and they've been good so far. I can't vouch for 100% of them, but what I've done has been helpful. On PESI, there's a complete guide to becoming an LGBTQ affirming therapist, which I think is a solid training. And then WPATH does have, I think the GEI stands for like Global Education Initiative or whatever. Anyway, they have courses and a certification you can do. I haven't done any of the courses, but looking through them in the course descriptions, they sound helpful. So I think it's worth looking at. Also, the APA Division 44, their LGBTQ division, has awesome resources. There's fact sheets, newsletters, position statements, and more stuff on their website there. In particular, I think the fact sheets can be really helpful in educating clients, or if you're working with kids or teens, educating their parents. They're concise, easy to read and digest, just generally pretty well done stuff. There's conferences you can attend. Now, most of these got quite disrupted during COVID, but seem to be coming back. There's the Philadelphia Trans Wellness Conference, which is a big one. There's Gender Odyssey in Seattle and LA, and Gender Spectrum in Hayward and LA. And there are more out there, but these seem to be the big ones. Oh, maybe I would add, there's also the one that Margie is putting on here in Juneau next year. Could have added that to the list. Books. I love books. I had to cut down how many books I was recommending. So the Clinician's Guide to Gender Affirming Care, and LGBTQ Clients in Therapy by Jacourt. Those two I think of as like really the basics. Like if you are looking for like the best introductions, go there. They're great. They're straightforward. The Gender Affirming Care book isn't even that long, but it is, I think, pretty comprehensive. And it has good stuff in it. Like I read it pretty far into doing this work actually, and into my own transition. And even still, there was stuff in it I took from it that I found useful. So you know, great introduction, but useful to anybody at any stage of this. There's the Introduction to Transgender Studies. It's a just solid textbook. It's really good. There's the book I mentioned earlier, Gender Trauma by Alex Infante. It's just like a super good exploration of like how our like colonial-based attitudes about gender can be traumatizing. And then our local folk, Aiden Key, has a book, Trans Children's in Today's Schools. So it's not normally, or it's not really explicitly targeted at mental health clinicians, but I think it's invaluable to clinical work, especially if you're working with kids and teens. But as well, it has value even when working with adults. So, because I think in particular, seeing like the existence of and challenges faced by trans kids in what are historically fairly regressive conservative institutions, schools, gives a lot of really good insight on how to best support these folks. Seeing how these systems and structures create and reinforce bigotry and oppression, I think is integral to understanding that gender dysphoria is not like being born in the wrong body, but rather like a much more complex socially based experience of attitudes, beliefs, perceptions, and categorizing. Also, Aiden has, I think, the best response I've read to the question of like, what's up with all the trans kids these days that I've read. I think maybe my own response is pithier, but not quite as educational or welcoming. So I would recommend you read his if you're curious about that. Stuff for clients. So first, the workbooks. The Queer and Transgender Resilience Workbook by Annalise Singh is solid. It's great. It's intersectional. It's you know, easy to use. I think it's a really well done workbook. And then there's a gender identity workbook for teens, which is a good one too. Whipping Girl, I think is probably, to me, the best thing I've ever read on what it's like to live as a trans woman. And just one of my favorite books I've ever read. But if you're looking for something less dense, What's the Tea by Juneau Dawson is a great introduction that's a little lighter, more accessible, and approachable, I think. On YouTube, there's all kinds of like great trans creators of all sorts. Some of the ones that I found to be useful and helpful are Abigail Thorne, who runs Philosophy Tube, and she has a video called Identity, a Trans Coming Out Story, which I think is maybe the best description of what it is like to experience being trans, especially pre-transition, that I've ever heard and resonated more than anything I've articulated about my own experience. There's also people like Mildred, who has an essay on transsexual suffering, which I think is an excellent like history and ContraPoints. Really, any of her videos, I put gender critical there, but just watch them all. Great. And then Reddit has seemingly infinite resources, which a lot of which are actually like fairly decent. And some have things you can't really find other places. Like there's a subreddit called Transgender Surgeries, which holds a wiki of people who provide different types of trans surgeries that has people's experiences going to those doctors, because that's stuff you can't often find anywhere else. All right. Okay, and then I also think critical are books about sex and queer sex and trans sex. As you probably noticed in the discussion of HRT, there's significant changes to our genitals and the sexual sensation if we take HRT. So changes, especially if you're doing medical transition and you're doing HRT, changes to how we have sex are inevitable. And the changes can be confusing, scary, they can cause relationship difficulties and discord. And it can also be one of those powerfully affirming experiences a trans person can have, is to have affirming sex. So I think all four of these books are wonderful, great resources. And I think being able to aid a client in that is a really powerful thing. I would say, even without HRT though, sex can be a source of significant challenge for trans clients. Like helping a client explore their options in an affirming sex positive environment can relieve so much fear and be a significant balm to the physical dysphoria and the dysphoric experiences of like social roles and expectations and all the crap that goes on when we have sex. So yeah, I think it's worth knowing about, talking about, and solving. All right. Okay, last part here. The WPATH Standards of Care. All right, first off, what is WPATH? What is this thing? Why do they get to make the decisions? It's the World Professional Association for Transgender Health. They first published a guide in 1979 under a slightly different name, but whatever. It's currently in its 8th version, and their stated goal is to provide clinical guidance for health professionals to assist transgender and gender diverse people with safe and effective pathways to achieve lasting personal comfort with their gendered selves and to maximize their overall health, psychological well-being, and self-fulfillment, which is quite the run-on sentence. So anyway, we can go through and you can see if they are fully living up to that. They really do set the standard for transgender people within the medical system. Most insurance companies are going to require that these standards are followed to reimburse services. And consequently, many surgeons and other professionals follow these standards. But I mean, they're also doing it as a way to avoid malpractice lawsuits, presumably. But yeah, effectively, this is the standard. All right, so how do we do it? Step 1, diagnose it. So generally, the descriptor that DSM-5-TR gives for gender dysphoria is that it's a descriptive term that refers to the distress that may accompany incongruence between one's experienced or expressed gender and one's assigned gender at birth. So it's a bit different to diagnose than many other conditions in that it's a socially constructed condition. Everyone expected, not that there aren't others, but it is one of them. Everyone expected a child to fill a socially constructed role based on the appearance of their genitals when they were born. And it turns out that there isn't a perfect binary, which is to say nothing of the experiences of intersex people. If we left the door open for every child to like express their gender in whatever forms feel right, then the disorder might start to seem almost unnecessary. We're already starting to see it with like some Gen Z and Gen Alpha kids. Like I do have kids coming into my office who are like, yeah, I'm not that bothered by it. Like it's annoying that there's all these gatekeeping and hoops to jump through and so on. But like, they're sort of like, everybody in my life accepts me. It's fine. It's pretty mild, their experience of it. And there's even from earlier, I mentioned there's on YouTube the person ContraPoints Natalie when she had a quote that's like, Did you know there's some trans Gen Z kids out there who don't even hate themselves? Like it's this sort of generational divide even between like millennials and Gen Z. Um, if we assume the possibilities of like a baby born with like any genitalia, including intersex folks, they could just grow into whatever felt good, and the possibilities are infinitely broad. And there might not need to be an incongruence if a person with any genitals could be anything. It's instead the expectations and assumptions that we place on these kids that start to cause this as something diagnosable. In particular now ICD coding. So those codes F64.0, which is coded as transsexualism, and 64.2, gender identity disorder of childhood. So you'll notice like there's a difference that the ICD uses the term disorder, the DSM does not. The DSM explicitly acknowledges that my experience of gender dysphoria is a condition, which is a result of social constructions. Whereas the ICD posits that I'm disordered. So really cool of them. Which leads to this, one of my favorite tweets. How many trans folks does it take to change a light bulb? Only one, but they have to live for a year in the dark to be completely, absolutely sure it needs changing and have the confirming opinions of 2 electricians, at least one with a PhD. I mean, it's poking fun at this inherent contradiction in the medical model of care. Like, I need someone to tell me I'm trans and that I'm okay to decide that I'm trans, that I'm part of a social category that by definition, only I can decide whether I'm a part of. Like it's about my self-perception and my labeling of myself. It's a bit ridiculous, this practice of medicalizing the social category the way that we do this, and often begins to make no sense in practice. But also don't tell Blue Cross that. I need them to pay for stuff. It's worth noting, like cis people get gender affirming care all the time. Like when a woman takes estrogen to ease the effects of menopause, or a man takes testosterone or Viagra or minoxidil, they don't need to justify their gender to any authority. They typically just get the medical care that they're requesting. But if I need the same thing, like if I need estrogen and a cis woman needs estrogen, I need to justify my gender identity first. And I just bring it up to help you understand that like there is this vulnerable, infantilizing position your clients might find themselves in. The medical model of care for trans people puts us as therapists too in an extremely unequal position. It asks us to be an expert, an assessor, and part of a gatekeeping system to the client's necessary life-saving medical care. It has the potential to disrupt and ruin the therapeutic relationship, so you need to manage it with extreme care. So I've probably articulated some of these in some forms, but the main criticisms that you can find are the standards. They're not actually really based in any peer-reviewed research or evidence, and that they show no tangible benefit of harm reduction, like when you compare it to an informed consent model. So in a sense, we don't even need them. And the WPATH standards, it's documented, they've led to trans folks feeling stigma, being discriminated against through like more layers of gatekeeping, and feeling more marginalized. Okay, so the letters themselves that we're asked to write, what are they? They're letters to confirm that you've assessed for the criteria laid out in the current WPATH Standards of Care, and they're minimally invasive. I've had reports from clients who've had providers ask like all kinds of unnecessary invasive questions that really just show like a clinician or doctor's pure curiosity. Things like, and promise is true, things like how the client masturbates, what they think about during masturbation or sex, diversions into their sexual orientation that aren't really related to their gender. So we're really just doing the minimum here. There's no need to go above and beyond if the client doesn't want to. And when we get to the criteria, you'll see what they are and see why those things, like how somebody masturbates or what they think about, are not necessary to make an assessment here. And it's because what these letters are not, they're not an assessment of whether a client is like quote unquote really trans. And they're not a full disclosure of the client's mental health history either. I think in some experiences I've heard people feeling that way too, that their entire mental health history gets released, but it's actually not necessary when we look at the standards of care. So who can write a letter? Well, a licensed clinician. Oh, I should also clarify first. This is from the most recent standards of care, version 8. You might see other slightly different standards if you can write a letter, which are based on older versions of the standards of care, but I'm just going to use the current ones. So any licensed clinician, doctor, or a nurse practitioner or PA with applicable training. So I would assume that meant like a psychiatric nurse practitioner or something like that, but it hopefully does not clarify what that is. But it says that you're supposed to have had training in diagnosing via ICD-10, that you can identify coexisting disorders, you can assess capacity consent, you have knowledge about trans and gender nonconforming people, and you can treat gender dysphoria. How much knowledge, what kind of knowledge, again, not explicitly defined. And that it says you have continuing education and treatment of gender dysphoria. How much, who knows, doesn't say. Again, very helpful and specific. All right. Before assessing and writing the letter, the things you're looking for, we want the client to know which procedures they're asking you to write a letter for, sort of the basics. They should hopefully know which surgeon you're writing the letter to, and the approximate, or if it's to the insurance company, to them, the approximate date of the procedure, because some insurance companies and providers will want the letter to have been written within a certain time period before the procedure. Like they might ask for 6 months or 1 year. I mean, it varies, but that's somewhat common. You might want to have obtained an ROI for their surgeon, and hopefully the client has talked to their insurance company about what the insurance company's requirements for the letter are, because they may differ from the WPATH standards. They're sort of, in a sense, not supposed to, but of course in practice they often do. Okay, and then what are we actually asked to assess? So first off, gender incongruence is marked and sustained. Again, helpfully, no timeline or guidance on that criteria is given within the new standards of care. It's often interpreted as identification or living as the identified gender for 1 or 2 years, depending on the medical provider. But the standards also state that a client does not need to have lived as their identified gender to access care. They can still qualify for care without having begun their transition in any other form yet. So that interpretation can't be correct. My personal standard is I just ask the client when their identity came to conscious awareness and if that conscious awareness has been sustained. And that's what I use. So you have to identify that the client meets the criteria for gender dysphoria, identify and exclude other possible causes of gender dysphoria. I'm always kind of curious what those other causes are, but yeah, you're supposed to eliminate them. Identify that other mental health conditions that can negatively impact outcomes have been identified, and risks and benefits discussed. So it's not that having another mental health or coexisting condition disqualifies you from accessing care, but rather just that you need to have discussed the impacts of it and the risks and benefits, and that the client understands them. And then same again with physical health conditions. We need to assess that the client has the ability to consent. Now, in the standards of care, they say that their standard is what is reasonable to expect, that the client understands what is reasonable to expect. They ask the clinician to identify that they understand the risks and benefits of the treatment. They understand the possible range of outcomes, and that the client can retain the information with the use of aids if needed, like visual aids, but that they can retain this information and make an informed decision, and that they have the cognitive ability to utilize like a risk benefit analysis in making their decision. We have to assess that the client fully understands the impacts of what will happen, and assess that social transition is happening, or that it will happen subsequent to the medical intervention. If there hasn't been any social transition yet, we're simply required to determine that the treatment will be beneficial to them. And so that's what I was saying earlier, is like, you don't have to have socially transitioned, you don't have to have lived as your gender. It just has to have some kind of benefit to you. Presumably it relieves dysphoria in some way. And then last, specifically if somebody's getting an oreectomy or gonadectomy, which is removal of the testicles, the standards identify that they should have been on HRT for 6 months, unless it's clinically indicated that they can't take HRT. Okay, lastly, what is technically not required? A severe level of distress resulting from gender dysphoria. The amount of distress caused is never like stated as a requirement, or really that any be there. In some sense, there needs to be some amount, I guess, to diagnose gender dysphoria, but it can be fairly mild. New to the standards of care 8 are that a second opinion or assessment is not required. Kind of makes that other joke about having 2 electricians check that your light bulb is out of date, but those are the new standards. And then lastly, we really do not need to acquiesce to every request from an insurance company. They often ask us to ask unnecessarily invasive questions, or they ask for unreasonable documentation, or they have such onerous expectations on your client that they just can't be reasonably met. And so in this sense, this is where the standards of care can come in handy, in that we can use them to push back and say, hey, no, like what you're asking for is not identified by WPATH in the standards of care, like this isn't necessary. And sometimes that works, but of course, sometimes it doesn't. All right. I haven't done this yet, so hopefully in the coming days, a letter template will be sent out to everybody so you can see what one might look like. I'll try to get that done by the end of the weekend, maybe. All right, and yeah, perfect. We have like 10 minutes, so questions?
Maybe I'll ask a question while folks are thinking. I'm curious, like what you would, obviously the folks who are here have now seen this presentation. If there's a provider who hasn't written a letter before, but their client is asking for one, where do you suggest they start? Like, should they just write it? Should they be paying someone to help them learn how? Like, what's the best way to get started if you haven't written one before?
I guess what I would suggest is to ask your client to get the requirements from the insurance company or the surgeon, what they're looking for, see what they're asking for, and then just check in with yourself about your level of confidence to assess for those things and to write a letter confirming that you've done that work. Because ultimately, like, the standards of care are standards, but they're not like legal requirements or anything like that. Like, ultimately, you just need to provide whatever you are asked for by the insurance company or the doctor. If you feel out of your depth or you don't know how to write something up, then yeah, you can ask for help. You can pay somebody like me for my time, but there's also examples online that you can look up of these letters. Different organizations of medical organizations have sample letters that you can look at of, I think, varying qualities, but they're out there. So those are good places to go to.
Amazing. Is there anyone besides me because I can keep asking questions, but is there anyone else who wants to come off mute or type a question in the box?
This is
Margie?
Noelle.
Oh, Noelle,
Can I
yes,
ask a
please.
question?
Please.
Yeah, sorry I'm in transit, so I can't have a video. But hey, Amelia, I'm really curious if there's any groups here in the state that you know of that are doing any kind of group supervision, or if you know any supervisors should we want, or people who are doing consultation. Maybe you just mentioned that you're doing some. I wasn't sure. But could you speak to that, or maybe send out information later if you have any to share?
Sure. Yeah, I mean, I do offer consultation on it. Not clinical supervision, but consultation. I'm trying to think, I think I do know of one or two other people in the state who also offer consultations. In my experience, most people are just part of, there's like queer providers and trans provider Facebook groups and things like that that people use as resources often to get support and education on things. But yeah, I can also, yeah, let me look at what I have and see if I can send out anything else too.
Amelia?
Yeah, hey Margie.
Hey, this is Margie. I have a little vertigo, so that's why I'm sitting here. I was all propped up. Fabulous presentation. Really, really great information. I wanted to just reply to Noelle and let her know that I also do some supervision and consultation with clinicians, but also with agencies as well. And there's going to be soon a group supervision statewide that Eli, oh, I've lost his name.
Michael?
Yes, Eli Michael and myself will be starting probably in January for people who are really interested in LGBTQ and especially trans issues. So those will be coming up. But anyway, just want to mention those are out there. And also kudos again, Amelia, for a really good presentation.
Thank you.
For the recordings, I saw someone asked about that. They will all be up from last year's and from this year's. Amelia did a wonderful presentation last year, as well as did Margie, at namijuneau.org/inside passages or on the NAMI Juneau YouTube channel. So those will both be there. Noreen, did you have a question?
Yes, I do. Not a question, but a comment. Thank you so much for Amelia for this beautiful presentation. I really enjoyed it. And I would like to thank Meryl and NAMI for providing this beautiful webcast today. And I'm looking forward to working with diverse peoples in the future. And I'm so excited. Thank you so much.
Yeah, of course. Thanks.
I have a quick question, Amelia. You had mentioned that there was a conference in town that was happening next year, and I was curious if you'd be able to repeat the name of it, because I know it wasn't on the slide, so I was just curious.
Oh yeah, yeah. Margie, correct me if I'm wrong. I think it's Affirming Our Identities. Is that right? And it's in May of next year.
Sweet, thank you.
Yeah.
Yeah, Margie, do you want to share where people can find more information about that if they're interested?
You bet. I think Amelia has one of her tabs is open at Affirming Consultants.
Oh,
Next May, there will be a conference here in Juneau. It's going to be Affirming Our Identities, Awareness to Action, and it's going to really focus on a lot of different identities that people have, immigrants, transgender, homeless, seniors, just lots of different identities. And it's going to be a really neat opportunity to have some national presenters as well as some local presenters talk about different things that, just like this presentation, can help us be more culturally aware and also be able to change little things even in our own practice to be more culturally sensitive to the people that we work with. And so this this page, affirmingconsultantsandcoaches.com, has all the details and registration, and has who some of the speakers are that are already lined up. And it also has a call for presentation for speakers who we're going to have 20 breakout sessions. And it's hoping to have about 100 people locally and 100 from outside. So yeah, thank you for putting in the plug or for asking about that as well. I would love anyone who's interested in being involved in whatever capacity to get in touch. Yeah, thanks.
Thanks, Margie. Any last minute questions before we wrap up? Thank you so much, Amelia. Like Amelia said in the beginning of this presentation, I asked Amelia to speak on some of these more technical things today because I've just seen that it is a gap in the community. And I really wanted a resource that we could share with providers who were interested in becoming more competent. I know, like for myself in this last year, I got gender confirmation surgery and I had to get one of these letters, and I got one from a therapist who had never written one before. And so we kind of went on a journey, and I just personally was like, wow, I really wish there was a YouTube video I could send of where to get started. And so I just know that this is gonna help a lot of people. And also I just want to say, like, for providers who haven't done this before, I know that it can seem overwhelming and scary, and it's super possible. And it meant a lot to me. Like, I think when Amelia talked about how this process can damage the therapeutic relationship, it meant a lot to me in my relationship with my therapist that she was willing to write me this letter, and she was willing to go pay for education so she felt confident in doing it. And so I think that just keeping that in mind, like, it is possible, and Amelia has strengthened us with so many resources today, so that more providers here in town can support all of their clients. So thank you so much, Amelia. Thank you so much to everyone who came today.
Yeah, thanks so much again.
Have a great rest of your day, everyone. Please reach out if you have any questions. Bye, Noreen.